Good afternoon. We'll now start. It's already 2 o'clock. First of all, I'd like to welcome everybody to this pep talk today. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include the names of your companions attending with you. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and end of the pep talk. As a reminder, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link is already in the chat box, and I also have posted it in the Viber group and also in the Facebook group. Another reminder, 50 OLETE certificates will entitle a participant to 1 voucher for ROJoson telemedical consultations, like the one shown here. Another request is those who are not planning to take the OLETE, in which I ask for feedback to my pep talk, please type in your feedback in the chat box during the open forum or before we part ways. Thank you. So let's now have a group picture taking before we start the pep talk proper. Okay. Everybody ready? Okay. One, 2, 3. 1, 2, 3. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. And from October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer depending on the enthusiasm of our participants. Then my pep talk today is entitled Cancer Incurability and Hospice Care. This is part of the health issue course. The empowerment objective is for the lay people to have an understanding of cancer incurability and hospice care in their health management. The contents of this topic will be what is cancer, what is the basic cause for cancer, what is cancer incurability, when do you stop cancer treatment because of incurability? Because there will be a point that you may have to decide to stop. What is hospice care? What are the essential components and issues on hospice care? And what are my advocating statements and advice on cancer incurability and hospice care? Okay, as a review, for those who have been attending this pep talk, cancer is a medical disease when some of the body's cells grow uncontrollably with the potential to invade the adjacent body tissues or organs and to spread to distant tissues or organs. So this shows the normal cells and then cancer cells growing and then slowly invading the adjacent tissues. Okay. This illustrates the spread. Okay. The original tumor is on the colon. It has spread to the lungs. Okay, so it can spread to distant organs. So cancer has that potential. Cancer is basically a genetic disease that is caused by changes to the genes that control the way our cells function, especially how they grow and divide. It covers a wide spectrum of diseases characterized by uncontrolled cell growth, which is driven by the so-called downregulation of tumor suppressing genes, meaning this suppressing gene fails to stop the uncontrolled cell growth. And the other possible mechanism is the upregulation of the tumor promoting gene. So there are some genes which allowed uncontrolled growth. Okay, so basically these are the two mechanisms, but how they do it up to now, we don't clearly understand the mechanism. Now let's go to a cancer incurability. But before that, the conventional definition of a cure or medical cure is that there is a condition, medical condition or disease that is completely gone after some time, after treatment, and will never come back. So that is the strictest definition of medical cure. Cancer incurability may either mean the cancer cannot be cured anymore, or there is no cure for cancer to start with. Okay, for those who believe that there's no cure for the cancer, but from the very start, this is also defined as cancer. This is under the concept of cancer incurability. The question is this true? So I guess we just have to qualify the answers and the context. So before answering the question on cancer incurability, allow me to discuss first the concept of incurable disease. Okay. So any disease for that matter, there are some diseases aside from cancer which are also incurable. Okay. A medical condition or a disease that is persistently present and does not disappear or keeps on coming back after some quiet or remission time until time of death of the person is, strictly speaking, incurable. So yung di nawawala, palagi bumabalik. Na? Okay, examples are diabetes, hypertension, arthritis, asthma, Alzheimer's, and cancer. So these are classified under incurable. Okay. Incurable diseases are usually chronic, but sometimes they can be acute. Chronic diseases are defined broadly as conditions that last for 1 year. Some authors would use 3 months or more and require ongoing medical attention or which can limit the activities of daily living or both. Okay, so this is the definition of chronic diseases. Duration usually matagal. Okay, 1 year, 3 months. Okay, now incurable diseases may also be acute, in the sense that it's incurable, but it lasts only for a short time and the patient dies soon. Okay, so this is the concept of acute na incurable diseases. Okay, yung chronic, incurable, matagal yon. Okay, so examples of diseases that are incurable and chronic, matagal, okay, but at times acute will be diabetes, hypertension, arthritis, asthma, Alzheimer, and cancer. So, incurable diseases can also be classified as chronic. Kanina, chronic and acute. Ngayon, chronic terminal illnesses or chronic non-terminal illnesses. So, dalawang classification. A chronic terminal illness, it's an end-stage disease that cannot be cured or adequately treated and controlled anymore, and is reasonably expected to result in the death of the patient within a short period of time. Yes, sinabing terminal. Okay, so this term is more commonly used for yung mga progressive cancer or diseases such as cancer, dementia. Okay, yung lumalala over the years. Okay, advanced heart disease. Okay, this is not used for injury. Injury usually susugpo naman, no? So it's not a terminal illness. Okay. Now, the other counterpart is non-terminal, chronic non-terminal. Okay. So it is also a chronic disease, although cannot be cured or adequately treated and controlled anymore, but is reasonably not, a patient is not expected to die within a short period of time. Okay, so this term is more commonly used for non-progressive or slow diseases, mabagal, no? Such as arthritis, hypertension, that can be controlled and the patients can live with them with a quality of life all their life. So this is the so-called chronic non-terminal in contrast to the terminal, chronic terminal. So looking and focusing now on cancer, earlier I made an intro on the incurable diseases in general. Now let's focus on the cancer. So if it's incurable, it may be classified as chronic or acute. Chronic means long-term, okay? Acute means short time or short lifespan. Sandali lang, 1 month, 2 months, namamatay na yung pasyente. Or it can also be classified as chronic terminal, causing death soon, or chronic non-terminal diseases, not causing death soon. Okay. Going back, so the question, is this true? Okay. Is cancer really incurable? Okay. So as I said, we have to qualify the answers in the context. My answer at this point is that the answer can be yes and no. Yes, because physicians up to now do not know the exact cause of a particular cancer in a patient, and most of the treatment done are not directed towards the triggering cause. The one that triggered the development of cancer. So the usual treatment that we know of, such as surgery, radiotherapy, chemotherapy, and hormonal therapy, and other drugs, okay, are just directed towards removal or dissolution of the cancer tumors, and afterwards just doing surveillance and hoping for a non-recurrence. So the other reason why they would say that cancer is incurable, because majority, if not all, the physicians will not guarantee cure for a cancer treatment. They will not commit to an assessment of cure after a cancer treatment, even if there are no evidence of residual or recurrence anymore. They would just say no evidence of recurrence. They would just say a patient is in complete remission, even if there is no evidence of cancer recurrence. They just hope and pray for no recurrence, but yet ready to be confronted with one. Okay. So yes, cancer could be an incurable disease because majority of cancers recur after some time, short time, or even long duration. Sometimes after 10 to 15 years, they can still recur. So the other side of this question is cancer is not an incurable disease because there are patients who have cancer who have no cancer recurrence after treatment. So they are in remission for a long time, say 15 years or longer. So for me, they should rightfully be considered as cured for cancer. They are the real cancer survivors. There are patients who have no cancer recurrence after treatment in remission for a long time, say 10 years or longer, then they die of a non-cancer cause. So again, they can be considered as cured for cancer. So my personal stand here is that no, not all cancers are incurable. Some are curable. There's still a chance for a cure if there is early treatment and there are effective treatment that is based on evidences. My other personal stand is that cancer may not be curable if there is no known effective curative treatment in whatever stage of the cancer. Okay, even for sometimes even in stage 1, there's no known cure for it, so we can call it incurable. And then the other premise is that if the current stage at the time of the consultation is that it's already far advanced, it can no longer be treated with a curable intent. Okay. So when you say that the cancer is already far advanced, usually the cancer has grown too big, masyadong malaki na for treatment to work, or it has spread to distant organs, or the so-called metastases. So why is it important to know the concept of cancer incurability, which is part of this talk? Okay, because one does not totally lose hope right away when one has cancer, but one also has to accept that some cancers are incurable, and in some cancers, one may have to let nature take its course. So the importance of knowing the concept of the incurability is that there are a lot of patients who just keep on trying, go all out, despite the fact that the cancer is already incurable. Okay, so it will end up with futile attempts to cure the cancer. The other reason for knowing the concept of cancer incurability is that it can promote sound decision-making by both the patient, relatives, and the physicians. So they will formulate realistic goal of management, whether it's just palliation lang or curative pa rin, no? And then promoting quality of life, and then facilitating advanced directive or end-of-life preparedness. And then, of course, it can help in the control of the unnecessary expenses. So when does one declare a cancer to be curable, not curable, and under not curable, whether it is terminally incurable already or not yet terminally incurable? Oh, for me, I just listed down these parameters for simplicity. Okay, so you take note of the track records of the specific cancers. Okay, because different cancers have different behaviors, different track records, and then the stage of the cancer, whether early stage or late stage, then behavior of the cancer itself, whether it's fast growing or slow growing, or it has a notoriety for keep on recurring, and then the presence or absence of effective curative treatment. So just use these 4 factors to answer this question. When does one declare a cancer to be curable or not curable? So applying these parameters, when does one declare a cancer to be curable? Curable first. Okay, let's start with curable. Okay, so when there is a track record of that particular cancer that shows that it is curable, meaning the patient is in remission for 10 years, 20 years, 50 years with no recurrence. And then if there is an early stage of cancer, okay, usually curable stage, and then slow growing and not recurring, observed over time, okay, and then the presence of effective curative treatment. Okay. So if these 4 are present, you can say that the cancer is still curable. When do you say or declare that a cancer is incurable? This is in general muna, no? Not the chronically terminal, chronically not terminal. It's incurable if it has a track record that it is incurable. It is in the advanced stage. It has a history of fast growing and keep on recurring. And then there is the absence of effective curative treatment. Now, when do you say that a cancer is terminally incurable? Okay, so this is when the patient is expected to die within 6 months to 1 year based on medical experience. Okay, so same year, incurable, track record, incurable, advanced stage, fast growing, recurring, and progressive, tuloy-tuloy, and then absence of effective curative treatment. Because we're talking about terminally incurable, so these are in the patients in which you expect them to die within 6 months to 1 year. And when do you say that cancer is not terminally incurable? So when you don't expect the patient to die within 6 months to 1 year based on medical experience. It could be 2 years, 3 years, or even longer, or even 5 years, 10 years. Okay, there are some cancers, you may have this cancer there, but it can last for 10 years, okay, sometimes. So once a patient is declared to have terminally incurable cancer, what should we do next? Okay, so what should be done next? So important in the decision making in such cases is that we have to formulate a realistic goal of management. Okay? Usually, we choose palliative and hospice, no more curative goal. Okay? And then we try to find ways on how to promote the quality of life, and then we facilitate the advanced directive or end-of-life preparedness, and then we try to control the unnecessary expenses. The realistic goal of treatment should be one with palliative intent, with hospice care. We're talking about terminally incurable cancer. Okay? Palliative intent with hospice care, so no longer curative intent. The goal is just to promote quality of life in whatever remaining years and months of life of the patient. And then no more active anti-cancer treatment. Okay? So if you reach a point that you declare a patient to be terminally incurable cancer, you can stop the active anti-cancer treatment already. So, but when do you when the patient is declared to be non-terminally incurable cancer, kanina we were talking about terminally curable cancer, but this time we go to non-terminally incurable cancer. So the question is, what should be done next? Okay. So the realistic goal of treatment should still be one with palliation kasi incurable siya, no? Okay. But so no longer curative intent, but the goal is just to control and not cure the cancer with continued promotion of quality of life in whatever remaining years and months of life of the patient. But in this type of patients, if there's a decisions by the patients or the relatives or the physicians, active and anti-cancer treatment may still be done to control the cancer, in contrast to those with terminally incurable cancer, in which no more anti-cancer treatment, active anti-cancer treatment should be done. Okay? But for this one, you can still use active anti-cancer treatment because you still want to palliate. Okay? Approaches to treating incurable cancers, there are three approaches. One is, of course, we start with palliative intent, the intention, and then palliative care, okay, palliative care, and then hospice care when somebody is declared to be expected to die within 6 months to 1 year, then you declare a hospice care. Okay. Palliative care versus palliative intent, there's somehow there's a difference. When you say palliative care, it's the care given with no curative intent. Okay. So basically, it's just relieving the pain, symptoms, and promoting quality of life. Okay. Palliative intent is the intention. Okay. No more, in other words, no more curative intent. Okay. So when you say palliative intent of treatment, you can still use the anti-cancer treatment modality as indicated to palliate, no? And if still feasible, okay, you want to control the cancer, but it's not for cure, okay? And then the examples of anti-cancer treatment modalities include the following: surgery. Sometimes surgery can still be done for palliative purposes: radiation, chemotherapy, hormonal, and other anti-cancer treatment. So, hospice care will come in if the patient with a terminal incurable cancer has only about 6 months to 1 year left to live, based on experience, of course, medical experience and track records. Nobody can be 100% sure how long a patient will stay alive, but we just base it on statistics. Okay? Hospice care is still part of the palliative intent of treatment, except that the anti-cancer treatment is now withdrawn. Tigil na. Wala nang active anti-cancer treatment. So only measures, medical measures, supportive measures to care, to promote the quality of life that's remaining. Okay. The hospice care can be done at home or at the hospital or established hospice centers. Okay. Now, who determines the start of a hospice care? A physician usually, okay. A physician with experience who can reasonably say the patient has 6 months to 1 year to live. then of course the patient and relatives decide on no anti-cancer treatment anymore, just palliative care. So this is the start of the decision to, go into hospice care. A short history of hospice care. The concept of providing specialized care for dying patients, linking pain and symptom control with compassionate care began in England in 1950s, okay, not too long ago. So when a pioneering physician named Dame Cicely Saunders created the first modern hospice there in 1967. So there's a institution, there's a building that house this hospice care. In general, particularly in the US, when you say hospice care, they use this to mean when a person is expected to live 6 months, about 6 months or less, okay, if you let the illness run its course, 6 months. No? Okay, in the US, they have a system in which you can avail of the hospice care benefit. That's why they have to put a time restriction, 6 months or less. Okay? If it's more than 6 months, they're not qualified for the hospice care. But personally, I would choose 6 months to 12 months. Now, this is outside the medical compensation, financial compensation. Okay, so I would choose 6 months to 12 months. As it is hard to predict exactly when the patient is going to die and how long he's going to live. Diba? Mahirap talaga. The other prerequisite for hospice is the decision to withhold direct or active anti-cancer treatment. So when you decide that you want to go for hospice, there should be no more active, direct, and anti-cancer treatment. So basically what are done in palliative and hospice care. So the most important element is the pain management in terms of physical pain, mental pain, and of course, sometimes spiritual pain. And then promotion of quality of life until the last day of the patient's stay on earth or until the end of life moment. Ideally, there must be an advance directive by the patient in hospice care. So this is one of the first issues that we have to discuss in hospice care. An advanced healthcare directive or living will is an advanced healthcare planning in which the author or the patient or the person who makes this explains how he wants medical decisions to be made in case he cannot make decisions already, or even as early as now, if he can still make decisions, he declared it already. And then when the time comes that he is already unconscious, this will guide the people what to do. So by setting the contents of an advanced healthcare directive, the author is exercising his right of patient autonomy, okay, as what are usually placed in the directive are what medical measures he would allow to be done and what he does not want to be done to his body. Okay. For example, if he doesn't want to have intubation, endotracheal intubation through the trachea to help him assist him in respiration, he can state that that he doesn't want an endotracheal resuscitation or intubation. This document serves as a guide to the immediate relatives and significant others when the time comes to implement the contents, as well as to the healthcare professionals who may eventually be called to manage him, para alam lang lahat kung anong gusto ng pasyente. The other issue that we commonly see in patients who are dying already in hospice is the diet and fluids. Okay? So, kadalasan, sige pa rin, put in IV fluids because baka ma-dehydrate, no? And ganon, no? But take note that the issues here will be pag nag-declare na yung hospice, okay? Okay. So, these are some helpful things to consider in the diet and fluids. So take note that decreasing the food and fluid intake is a common natural part of the dying process. Okay. So talagang kakonti, wala masyadong appetite. Na? Most dying people do not experience thirst or hunger as death approaches. So wag na tayo matakot na gugutumin siya, okay? Or uuhawin, okay, because they do not experience it anymore. And then giving foods and fluids by artificial means, example, suero, intravenous, okay, or nasogastric tube, yung mga tubo sa ilong, okay, does not usually prolong life or improve its quality. Providing food and fluids by artificial means may in fact increase distressing symptoms such as shortness of breath, respiratory congestions, restlessness, nausea, and vomiting. When people have difficulty swallowing, eating, drinking may put them at risk of choking. Artificial hydration does not provide nutrition anymore. Artificial hydration does not usually prevent or improve thirst or relieve a dry mouth. Okay. So the best thing to do when you have a dry mouth is just frequent mouth care. It can relieve that symptoms, that discomfort. The other issue that you have to decide when you have a hospice will be the place. So you decide whether to have the hospice care at home, at the hospital, or at the hospice center if there is. Okay, there are only a few in the Philippines. Okay, so usually it's either at home or at the hospital. And then usually you also decide whether you want a patient, your relatives, or even yourself to die at home, a hospital, or hospice center. Okay. So these are the issues that you have to settle and then put it in the advance directive. Okay, use the advance directive to guide everybody. So here are my advocating statements and advice on cancer incurability and hospice care. All lay people must know the basic concepts, principles, and processes of cancer incurability and hospice care. And this is part of the patient empowerment program. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, at kapangyarihan to gain greater control over decisions in medical management of oneself and also your relatives by knowing the basic concepts and principles and processes in cancer incurability and hospice care. The 4 Ks that I mentioned promote sound decision-making by both the patient relatives and physicians in the realms of, number 1, formulating realistic goal of management, whether palliative or curative, promoting quality of life, and then controlling unnecessary expenses. One does not totally lose hope right away when one has cancer, if you know the concept, the principles, and processes of cancer incurability. It all depends on the situation, the type of the cancers, the stage, the presence or absence of effective treatment, etc. Okay. There are still some cancers which can be cured. Okay. So to give ourselves some hope, some optimism, and not all cancers are incurable. However, one also has to accept realistically that some cancers are really incurable and already incurable at the time of the diagnosis. So in some cancers, one may just have to let nature take its course, rather than just keep on trying, go all out and spend so much. So in the end, it will turn out to be futile. If the cancer is deemed curable, choose the best, the most cost-effective treatment to promote cure. But if it is deemed incurable already, still choose the most practical and most cost-effective treatment, but this time to promote palliation, okay, not cure anymore. If the cancer is deemed terminally incurable already, choose the most practical and most cost-effective treatment to promote a peaceful death. Okay. Terminally incurable already. Okay. Promote a peaceful death. So know the basis for declaring a cancer to be curable and curable. As I mentioned here, you make use of these 4 parameters: track record, stage, behavior, and presence or absence of effective curative treatment. And then decide on the realistic goal of treatment, whether curative, palliative, and then under palliation, whether it should be with anti-cancer treatment, kung pwede pa, to prolong, to palliate, or without cancer, anti-cancer treatment already at the time of the hospice stage. So for terminally incurable cancer, as much as possible, okay, or even those practically anybody, even with no incurable cancer, no. So what have an advanced directive, healthcare directive. Okay? So give details on how you will be managed or how one will be managed up to his last breath. Okay, place of care, whether at home, hospital, or hospice center, diet and nutrition, procedure, whether how aggressive would be the diagnostic test and treatment, etc. So sometimes you just have to let nature take its course. You palliate to promote a peaceful death, palliate to promote a quality of life. Hatties Bryant, one famous author, just mentioned, she has a book here. 4 steps to a peaceful death are the following. So acknowledge the inevitability of death. All of us will die. Understand the limits of medicine. Okay. There's always the limitation, hanggang saan lang yung medicine. Okay. That's why we have a saying that we cure sometimes, but we comfort always, we relieve often. No? Okay. Educate yourself about your healthcare choices. Then communicate your wish and choose a proxy through a advanced directive. So summary and takeaway for this course, for this pep talk will be, I discussed the following. What is cancer? What is the basic cause of cancer? Cancer incurability. When do you stop cancer treatment because of incurability? What is hospice care? What are the essential components and issues on hospice care? And what are my advocating statements and advice on this cancer incurability and hospice care? As I said, takeaway in relation to patient empowerment, be always in touch with reliable medical information on cancer incurability and hospice care. Knowledge is power, it gives power. Use the 4 Ks of power, patient empowerment, kaalaman, kakayanan, karapatan, kapangyarihan to gain greater control over decisions in medical management of oneself by knowing the basic principles and processes in cancer incurability and hospice care. So with that, I end my pep talk. I hope I have empowered you to have a better understanding of cancer incurability and hospice care in your health management. And then as a reminder again, OLETE, okay, and then 50 OLETE certificates, 1 voucher for a telemedical consultation. Okay, and then please put your feedback in the chat box if you're not taking the OLETE, or even if you're taking the OLETE, you can also put a feedback there. Okay. And now let's go to the picture taking before we start the question and answer session. Okay, ready? Everybody ready? Show your face. Last call, ready? 1, 2, 1, 2, 3. Okay. So the floor is now open for questions, comments, sharing of experiences, etc. Anybody wants to start? Are there questions already in the chat box?
Wala pa, host. Wala pa.
So last time we talked about cancer curability. Somehow we touch also on cancer incurability. Last time cancer curability, then And then survivorship, this time it's cancer incurability, but we added the hospice care, hospice care. So we have to be realistic.
Can I ask something? Sorry.
Sure, Susan.
Okay. My sister, who's a nurse, always tells me about ano ba yon, yung
Advance directive.
DNR, do
Yeah.
not resuscitate.
Yeah.
If that is what we put in our what do you call this? It's a patient plan, patient billing or something.
Yeah.
If that is the line we put, do not resuscitate, what exactly should the person taking care of the patient or the healthcare professional, what exactly should be done?
Number one, it's part of a billing. Yeah, that tama, billing, no? Okay. So do not resuscitate, and it's just one of the billing. There are other billing, no? Okay. And then you can, the one that I'm talking about, the advance directive, that's part of it. You have you have to prepare a ideally, kahit na wala ka pang parang ako, I don't have any cancer at the moment. I don't know when I'm going to die, but I know that I will die someday. Okay. And then I don't know when, it could be sudden. And since I want everybody to be prepared now, everybody, when I say everybody, my family will be prepared how to handle when the time comes, and also how I'm going to be treated. So I have an advance directive already. No? So in which I put there, if I die, if I'm going to be diagnosed to have a chronic terminal cancer, do not resuscitate me anymore. Do not put IV fluids. Do not intubate me. Do not put yung mga tube, yung mga chest tubes, maraming tubes, no? Do not dialyze me already, you know, etc., etc. Okay. So yun ang advanced directive, no? So you can prepare it even as early as now, hindi ka pa wala ka pang sakit. Okay, but a lot of people are being taught, actually, konti pa rin no? Konti pa rin, but that's my advocacy. A lot of people, when they become hospitalized, sige, hindi nila, it's either hindi nila natatanggap yung advice ng doctor na baka terminal na yan, no? Okay, they just keep their eyes closed, they just go all out, and then spend a lot of money, okay, on how to make the patient relatives live longer. Okay, so if you are in that stage when you're in the hospital, you can still do an advance directive, no? In the form of shortcut na lang, shortcut, no? Sabihin mo lang sa doktor, no? Do not resuscitate anymore. Okay? Yung DNR. Okay. Do not, meron pang iba dyan no? Do not resuscitate, do not intubate, no? Okay. So you can add some more, whatever you want, no? Okay. So, but basically, it's do not resuscitate, meaning wala nang trying to revive. Let's say, kung suddenly, yung isang terminally ill patients na biglang nawala na yung paghinga niya, heartbeat niya, okay? So, that means you tell the doctor, do not revive anymore. Okay? Kasi pag CPR, cardiopulmonary resuscitation, yan ang resuscitation, di ba? Okay, pag nag-CPR, okay, so if you're in the private hospital, that will entail some cost also. Okay, usually you call it team. So that may not be necessary. No? Okay.
But how does that doctor tell it to a close family without necessarily, like naalala ko yung father ko noon, hindi naman cancer, pero how does he tell it na yung close family hindi mas disheartened, yun mo na, hindi ma-high blood din?
Slowly try to time it also. No. Okay. So may approaches yan. Just like before, we never talk about mahirap magsabi ng cancer. But over the years, no, natatanggap ng tao with the word cancer na, di ba? So ganun din sa yung DNR, yung Advanced Directive, no. So there will come a time magiging popular na rin yan. So everybody will be ready to perceive, to accept those yung concept na yon, no? Slowly.
Okay, thank you.
Okay. Okay, any more questions? No questions?
Other thing, Doc, I'm sorry, I hope you don't mind.
No, I don't mind. Go ahead.
What if the closest family insists, he doesn't believe, hindi mangyayari yung mga ganon. Hindi ikaw ang Diyos, mga ganyan mga linya ng yan, meron pa yan. What does the doctor do?
He will ask the patient. He will ask the patient. Let the patient decide. Muna. If the patient has an advance directive, yan ang susundin niya.
Kung wala, Doc?
Kung wala, just talk to the patient. Kung ayaw, kung hindi makasagot yung sabi ng pasyente, sige, I'll go with my sister. Go ahead. Go ahead.
Okay.
So, but be ready to
Take the consequences.
Yeah, yung mga consequences, no? Okay.
Okay, thank you.
Any more?
Doc, meron pong isang question.
Ano yun?
From Jacqueline Tong.
Okay.
In a situation where the patient says DNR in his advance directive, then loses his mental faculties, but the family insists on trying to do something, what does the doctor do?
Your doctor should follow the advance directive. Advance directive. Unless kasi kung di siya nag-follow advance directive, he can be sued by the members of the family, especially yung baka meron mga family members na sabi ng patient, ng kamag-anak ko, wala nang resuscitation, wala nang DNR, pagkatapos ginawa pa ninyo at gumastos pa, kayo na magbayad, doktor, no? Ganon. Okay. So unless the family talagang as a whole, no, talagang lahat, no, unanimous, trying to negate the advance directive. Okay. So we have instances like this occurring also, no? So mayroong DNR, no? May Alzheimer, di ba? Ganon. Then relatives put the DNR, and then may isang relative na nagsabi na wag, tuloy ninyo, no? Okay, so tinuloy nga, ginawa na, pero the other relatives complain, no? So until they found out it was done, kasi they're ready to sue the hospital already, diba? Okay, so but the relatives found out that somebody dictated na ituloy ninyo yung resuscitation, no? So I don't know how it was settled, no? So strictly speaking, kung may advance directive na especially notarized siya, legal document, now the hospital will have to follow. Okay.
So the doctor can actually refuse.
Yeah, the doctor can refuse, no? Kasi sabi niya may advance directive, no? Kasi kung hindi siya mag-refuse, kung ginawa niya, he's caught between the devil and Deep Blue Sea. Baka ibang relatives, sinabi ng hindi, tapos ginawa pa ninyo. Yung iba naman, sasabihin niya, sana hindi na pinakinggan yung advance directive ng kamag-anak namin. Ganun. So the best will just to hold on to that document. No? Kung walang document, yan, magulo yun. Magulo. No. Okay.
Thank you.
Okay. Any more? Jocelyn P.
Another one po, from Jocelyn P. Tanong niya, if a patient decides to die at home, how can a doctor help the patient with regards to pain management at home?
Okay, when you say help, number one, consult, di ba? So, ang dali-dali ngayon, telemedical, di ba? Okay, pwede, di ba? Number two, kung yung gamutan will entail more sophisticated equipment, no? Then it's either the doctor will ask the patient to the relatives to procure, and then put it at home, and then probably hire a special nurse, okay, or a caregiver to do it. No, so those are two ways of doing it. No, okay. So, okay. Did I answer your question? Meron ka pang idadagdag?
Dok, yung pain management paano?
Kaya nga, pain man, tuturuan ni ng doktor kasi parang
Tuturuan ng doktor yung
Oo.
caregiver. So-
give the prescription kahit na through telemedical.
Mhm.
Through telemedical, sabi ko, okay, you need a morphine, di ba?
Aha.
Yung malakas na gamot. So,
Aha.
I will send you a prescription, morphine. You buy it. No? You take it at home.
Mhm.
Okay. So that's my way of helping rather than telling the patient. Kasi may mga ibang doktor walang yellow pad, wala yung yellow prescription. They don't like to spend on it. No? So they will ask the patient, you go to the hospital kasi wala akong yellow pad. So mapipilitan yung pasyente to go to the hospital. So what the patient will have to do is to look for a doctor who has a yellow pad. Like me, I have a yellow pad. I can issue the yellow pad and then padala ko sa Grab sa kanya, no? And then Grab or other, I'm not promoting Grab. Okay.
Yes.
So then meron ako mga instances like this. I give the prescription, then somebody came to my house to get it, then they bought it, no? Okay. And then the other one, kung let's say kailangan mag-injection ng gamot for pain, no? So you can okay. You can ask a nurse or caregiver or a doctor nearby, no, who can do it, no? Okay. Or the third part is parang if the doctor is willing to do a house call, di ba? Going to the house. May mga doctors na nag-house call.
Yes.
So that's another measure that you can do, house call. No? So did I answer your question?
Yes, Doc.
Okay.
Bale, patient should wait for the yellow pad.
Yeah,
Yellow pad.
yellow pad for the severe pain. Baka ang kailangan lang naman mefenamic. Kung mefenamic, ordinary prescription pwede.
Yes.
Okay. Okay. So the other, okay, if I answer your question completely already, then I'm just looking at that topic na dying at home. Okay, dying at home. Maraming sa atin, ayaw natin yung mamatay yung pasyente natin sa bahay. Di ba?
Because
I can understand. Kumisan, because of some belief, okay. And then sometimes they want the doctors to be the one to kumisan, they want the doctors to be the one to see the patient to declare, no? Okay, what yung pinaka end point, no? Ganon. So maraming reasons, no? Okay. So other reason would be other reason which I can see also kasi if the patient is dying at home, mahirap tingnan yung nagsasuffer siya di ba?
yes.
Kaya gusto nyo, I mean, parang ilagay na niyo sa hospital, no? At least may kwarto siya, you don't have to visit her every day, ganoon, no? At least may time na wala ka doon, no? Or kung nasa ICU, hindi mo siya makikita, no? Okay. So hindi mo nakikita yung nagsasuffer siya, di ba?
Yes.
So that's one weakness. But it really depends on the family. how they decide on it. No? I cannot dictate. No? So, but I'm telling you, those are some of the reasons why patients, why relatives do not want their sick relatives to die at home. No? Okay. Now, if
May I
you
share? May I share? I sorry.
wait, I'll finish this one. If you decide to ayaw niyong mamatay yung isang relatives niyo at home, if you send her to the hospital or him to the hospital, i-ready lang yung advance directive. Yan ang importante po. Advance directive. Na? Palaging yung advance directive. Telling the doctors, hanggang dyan lang, ganun ang gagawin. If you don't have the advance directive, they will try to revive a dying patient, even though they know it's futile. No? Okay? Even though it's futile. Sabihin natin, terminally cancer na talaga. Okay? Talagang last breath niya, huminto na. Kung wala kang advance directive, they will revive. No? So when they call for a team to revive, that will cost a lot of money. Now, in a private hospital, usually mga 200,000-300,000 right away yan. Na? Ganon.
Yes.
May team kasi yan eh. Yung tinatawag na code blue, code something, code CPR. Na? Okay. So just if you want the patient to die in the hospital, make sure that you have an advance directive. Na? Okay.
Thank you, Doc.
Susan.
Yes, Doc. Just a little sharing. In 1995, I was still young then and working. My father had a heart attack. This is not cancer, no, but I hope it's worth sharing also. And on and off, we were at the Makati Med. I didn't have that much money. I think the doctor realized, no. And the last time na he told me, take your father home, no. These are the things you can do. It just so happened that I had a niece who is a nursing graduate, no. Pero I knew, I don't know, he didn't tell me na talagang mamamatay na yung tatay mo, but ang sabi niya is, I have a father who died. I'm a doctor pa, sabi niya pa ganyan. So parang ano na lang. So in this room, one of the room downstairs, every time I see my father na natutulog na lang, yung pala comatose na. Hindi naman sinabi sa akin na comatose na, pero eventually namatay siya. Hindi ba dapat sasabihin din ng doktor
Na comatose na?
na mamamatay na yung father mo? Pero siguro ang way of saying it is just taking home.
Yeah, taking home. Because that could be another indirect way of ano.
Okay. Kasi
Okay.
I felt so distraught. I felt so siguro nga naawa lang siya sa akin din na wala nang dahil my God, at yung 10,000 at that time na labas-masok kayo was too much for my budget. I was just working in government.
Yeah. Okay.
Oh.
Tama yun, no? Okay. So ganon. So even as I said, even doctors are having a dilemma on how to deal with you. That's why importante yung ito yung pep talk natin so that you will have some understanding, no? You can also help, no? Doctors kasi we doctors, we cannot predict when the patient is going to die, di ba? Kasi kaya kung minsan some doctors will not say 6 months na lang yan, ganon, no? Ganon, no? Okay. So kasi pag sinabi mong 6 months, pagkatapos hindi namatay yung 6 months, no, sisihin ka ng pasyente, no? Okay, sabi yung doktor, 6 months lang, abot ng 1 year, di ba? Ganon. So but a lot of times I'm forced to be real, to be honest. So but I told them, I'm not God, no? Basta may isang premise ako, I'm not God, no? Okay, I can only base my estimation on statistics, no, and experience, no, ganon. So don't blame me if he dies earlier or later, no, ganon. Okay. So,
Thank you, Doc.
okay. Any more questions? So you know how to, basta dapat sa inyo, most important thing here is be realistic. Accept the fact that there are some patients with cancers which are not curable anymore. No? And then, number 2, always have an advance directive. No? Even as early as now, Kung wala, kahit na wala pa kayong sakit, wala kayong terminally incurable diseases, have an advance directive already. No? Because you don't know when we're gonna go. Diba? Okay. Okay. So, no more. Last call. It's 3,
May
5.
pahabol po. May
Okay.
pahabol si Jocelyn T.
Okay.
If a dying patient at home was given dormicum every few hours, will he or she still feel pain and hirap sa paghinga?
Dormicum is depende kung ano, kasi pain can be a physical pain or mental pain, no? Pain, no? So dormicum, ina-knock-out, kung mental pain, ina-knock-out yung ano niya, yung pag-iisip niya, di ba? So he could be, mawawala yung pain niya, di ba? Okay. Yung hirap sa paghinga will be, ano yun, from the very start, nahirapan siya huminga. Kung nahirapan siya huminga, I don't think the dormicum will help, no? Okay. But sometimes, kung wala naman to start with, wala namang problem with breathing, sometimes the dormicum can cause some side effects then, no? Difficulty in breathing, no? Okay.
Mm.
So, posible
But-
yun. Okay.
Pero hindi na ma-feel ng patient yung difficulty of breathing once nasa dormicum na siya.
Yeah, usually wala na. Pag,
Mm.
basta may adequate dosage of dormicum. No?
Mhm.
Kasi ako nasubukan ko yung dormicum, tulog ako for hours straight.
Ay,
Yes.
nako.
Okay, I don't feel anything. No?
Mhm.
Okay.
Thank you, Doc.
Okay. So, okay. So if there are no more questions, we call it a day. So, okay, I'm thinking of next topic. Next topic probably will be antibiotics muna. Okay, the lighter topics. How the use and misuse of antibiotics. No? Okay. So I'm just choosing mga topics which are common concern by people, by lay people. No? Okay.
Okay,
Okay.
Doc.
So,
Thank you,
okay. Sige. Bye-bye.
Thank you, Doc. Bye.
Doc.
Happy weekend.
Bye-bye.
Bye.
Bye, Doc.
Thank you, Doc.
Bye-bye.
Bye-bye.
Bye.